proportions of the domains of quality of life, all of participants had good um, um, performance in all the domains. This is also in keeping with studies done in Italy by Gulepe et al. Also keeping in studies done in Saudi Arabia, which shows that their patients had good quality of life in all the domains. Spirituality also, our patient had good quality of level of spirituality, which is also keeping with Sylvia et al., which shows that patients inclined to spirituality as a coping mechanism. Also a study done in America also shows that 91% of patients with schizophrenia involved in 2023, which shows that the patients perform very well in the quality of life domains. But however, our patients were not performing very well in the social, psychological domain, which we think is because of sometimes the cognitive decline in schizophrenia that could affect their psychological well-being. Okay, the study was also shows that gender was a predictor of spirituality. This is in consistent with other studies, which shows that women living with schizophrenia are more religious than men, and then they may relate, this could also be related that women are more into religious activities. The study also shows that ethnicity is a predictor of spirituality, which is in relation to the fact that ethnicity builds a sense of identity. Okay, the study did not go without some limitations because it's a snapshot study, then it doesn't depict any causal relationship. And then the study was also done in 2 centers, then we should understand that we can't use the study as representative of the entire country. In conclusion, our patients perform very well in the WHO quality of life, and then also social and physical domain was correlated with spirituality. Then therefore it is important we look at spirituality in the process of care when we are taking care of patients with schizophrenia. Thank you very much.
Thank you very much, Dr. Kalilu. Our next presenter is Dr. Kwabena Kusi Mensah, Senior Specialist Psychiatrist, Komfo-Anokye Teaching Hospital. Please.
Okay. Thank you. So good afternoon, everybody, once again. So I'm presenting from my my PhD project, and so I've been asked to condense 4 years of my life into 10 minutes. So I'll try and, of course, I won't cover everything. I'll just touch on certain things that I think are pertinent. Let's go straight into it. So my topic was in pursuit of home sense. So home sense is a transliteration of Efie Nyansa, that's a Akan expression. Conceptualization and culturally appropriate assessment of executive functions in children in West Africa. So, and that's downtown Kechitia. This will be the outline that I'll follow. Why I went into this topic, I'll give an overview of the concepts of key concepts. What is executive functions and what are something called conceptual and semantic equivalents. And then I'll discuss how I conducted the study. I probably won't be able to touch on all the results, so maybe just 1 or 2 key results and then the take-home message. So I got into this topic, as you know, Dennis was discussing, practical situation. I come back from Nigeria, we are doing child and adolescent mental clinic, and then we realized that, oh, this child looks like, you know, they may need some cognitive assessments. What are the tools? Send them to psychologists. The tools come and it's all over the place. You can see clearly that this child has a problem, or you can say this child is actually quite bright, maybe they're a bit hyperactive, but the questions on the assessments, especially with some of these intelligence tests, is not capturing as we can see clinically. So that's where I realized that no, the tools that we have, which are mainly Western derived, seem to not be capturing the psychological constructs that they purport to be measuring within a cultural context. So long story short, I decided to go into broadly skill development and how do we develop culturally appropriate tools for our setting. So in my reading, I came across this very interesting gentleman. Lev Vygotsky is a Russian neuropsychologist. He lived in the 30s. Well, he did his work in the 30s, died very young. He's been lost until very recently in Western psychology and psychiatry, maybe because he's from Russia, I don't know. But it's only in the 80s and 90s that now his work is being discovered. And Vygotsky said something very important and very interesting. One, that you can't, first of all, concepts are developed based on people's experiences, and then you can't assume that a concept that you have in a particular culture is translatable to another concept, because the children or the people in that culture may not have been exposed to that concept, which is a big assumption that a lot of Western tools make, that what we are measuring is universal. So, this is just a little funny concept. So I used to explain this one, I used like snow. That's me, by the way. This Kumasi, bush boy from Kumasi, I've gone to England for the first time to study for extended period of time. I thought I know about snow. I haven't seen snow before. So this was my reaction at the first time that I saw snow falling. But the point is, you can know about a concept on a cognitive or a head level, but until I've never experienced I know you see it on TV, but until you see it, I was very excited. My wife took the video; she was laughing at me, and I got this Krasini from Kumasi. That the idea is, so I know it at a semantic level, but I don't have a conceptual understanding of what snow, in terms of snowstorm, means. So it's the same thing. You can explain it to a child. We might even get a similar word. They might say, it's like the thing in the fridge or whatever. But until they've experienced it, they don't really have a conceptual understanding of it. And so if you go and assess that person for anything to do with snow, even a very quote-unquote, that I consider myself reasonably well educated, and yet look at me experiencing snow. So that's the whole point of it. Oh, sorry, more pictures. So the point is that simply translating the tool, which is what happens in the vast majority of cases. I did a systematic review. Most people just take the tool from wherever it's coming from and then forward and back translate it into the whatever language in Africa, and then say that they have adapted. But language is very complex, as you will see. You can use words, me and you can use the same word, but it means something different to the two of us. And that's what I mean by conceptual equivalence as opposed to semantics. Semantics is words. We must be careful that the words that you are using or what you've translated actually means, or the person you are saying to understands it the same way that you understand it. That's the whole point. And that was Vygotsky's. Since I discovered him, he's like, this guy is speaking my language. So executive functions is basically decision making. So we have a lot of CEOs here, chief executives. What do? They make decisions. They decide, where the money goes, who does what, and that kind of thing. So it's just basically the high level of decision making, planning, and that's what we mean by executive functions. And the part of the brain that is responsible for that is the frontal lobe, as we will know from. So when you have a problem with ADHD and so on and so forth, it's an executive problem. So I asked the question, can a later psychological construct, conceptualized, developed and measured from a Western perspective, ever truly be accurately measured in a village child in Africa? It depends on which construct you're measuring. But generally, yes, but provided you do certain things. You make sure that there's a good content validation of the tool you are doing, which ensures conceptual equivalence, and cross-cultural validation that ensures measurement invariance. I'll touch on measurement invariance shortly. So what I did was, so my first year I did a big systematic review which has been published, where I looked at all the tools that have been developed ever from 1890 till now to measure executive functions, and that had been adapted in sub-Saharan Africa and in developing countries to see what kinds of validations had been done. And the bottom line is not very good. This is content validations. Most did not do it. And then cross-cultural validations, when you see the red means that those who had done it was of very low quality. So you see that almost all the content validations were very low or low quality. Cross-cultural validations, not that impressive. Most people concentrated on internal consistency and then structural validity, and they say, we validated. That's something else altogether. So I sought to, like I said, yes, from that systematic review, I also found that the best, and best is a relative word, the most adapted to for Africa was a tool called Briefs, Behavioral Rate and Inventory of Executive Functions. It's an American tool. Even that one, it wasn't that great, but in the land of the blind, one-eyed man is king. So I picked that tool and said that I'll use it for my study. So I was looking to how do we locally conceptualize the thing that Western thought calls executive functions? How does a farmer in Kintampo, and those are the study sites, Kintampo, Kumasi, and Ibadan in Nigeria, how do we think about the behaviors that have been described as executive functions, and then also sort to do a preliminary content validation. So I conducted quite a lot of interviews, about 25 focus group discussions, 132 parents, 68 adolescents across 2 countries, 3 sites, as I mentioned, in Kintampo, in Kumasi, and then Fantinuta in Kumasi, and then in Ibadan. I also talked to teachers and traditional leaders, but that I may not have time to talk about the Fenyasa part. Maybe I'll touch on it at the end if there's a bit of time. Yeah, so just some interesting pictures. These are parents in Kumasi. 10 minutes is a lot. Oh, I love this village. But you say Krum. Who's from Kintampo here? There's nobody here. 4 minutes, sorry. Anyway, so these are examples of some of the items on the brief. Like just some of the questions on the questionnaire. So like for the parents version, I have trouble with jobs or tasks that have more than one step. So it's trying to ask about like distractibility, I think. That's the concept that you want to look at. And these are the questions that I asked. So I didn't ask the participants these questions. I asked them about the question. And that's what we call cognitive interviewing. It's a qualitative method. So when I asked the parent the question, I asked them, how do you understand this item or this question? Do you have any children or friends or siblings, children who behave in this way? Can you give me an example or describe a situation that fits this one? So like if you say, I have difficulty with multiple tasks, and then I ask them about this, about the question in their community. And that's where you get very interesting responses. So we did the analysis, and one of the main problems was conceptual equivalent problems for easy distractibility. Participants had a hard time grasping the concepts behind items pertaining to autism and ADHD related executive dysfunction. So what that means is basically that this tool, one of the things, executive function cuts across, it's transdiagnostic, so people with autism will have it, ADHD, so on and so forth. The point is that the items that target those conditions, the executive dysfunction in those conditions, were conceptually, it was all over the place. So if you use this tool in our environment, even translated properly, there's a high chance of false positives and false negatives that you are going to pick up with it. That's the summary of what this is saying. No time, so I can't give examples. Conceptualization of certain behaviors. I asked the question, do you consider this Dr. Yare or something that should go to the hospital? And I was at pains to make sure that this was even in the extreme. So like the child is always doing this type of thing. Interestingly, there was, for the general population, there were only 15% of the items, 55 items, that the parents said that this is something that should go to the doctor. Which means that for the rest of the items, it's either character flaw or spiritual, or it has nothing to do with, and this is in the extreme. There was also, I did a content analysis, and I was able to show that even in terms of the character flaw terms that were used, there were interesting generational differences in the terms that were used to describe the executive dysfunction. So parents, adolescents tended to describe it, some of them as just the person is being inconsiderate, whereas parents were using more harsh terms like stubbornness, laziness, playfulness, those types of things. Your picture exactly. So, and then I also, the content validation, I found interestingly that I could actually map the character terms to specific domains. So, for example, if a parent tended to say, if the items that were described as laziness tended to map onto the working memory domain. So that is also interesting because it means that if we get the tool in our own system and we get, let's say, a layman's version, and we ask, and then they are using terms like, oh, my child is always lazy. You can even figure out which particular, that's assuming that the laziness is really an executive dysfunction problem. You can even figure out which specific domain of the brain or of executive dysfunction that the child is likely to have a problem with, which has interesting diagnostics. There were other examples, but no time. So I want to talk about one more. Yes, the language dynamics. Language is, like I said, is very complicated. the study encountered translational deficiencies despite using the current gold standard, and that's what everybody does, forward and back translation. And yet there were issues that I had to coin expressions for them. Sometimes problems of target language conceptual overlap and then target language deficit. So what that basically I mean by that is that sometimes the translated word that you've used, so let me give a good example and then I'll stop here. If we say that in tree, so there's an item that says my child is fidgety, and then in tree we say that or keka keka, or petri petri, very good, petri petri, or we say, so sometimes we say keka keka now petri petri. I found that conceptually when you analyze the actual examples that they give, they are almost always exclusively talking about motor restlessness. It hardly ever covers I should say gross motor restlessness. It hardly ever covers fine motor. So a child who is always like picking up things. So in other words, if you have a child who is hyperactive or petri, and they just sit down, but they're always touching stuff, fidgetly, that term doesn't cover that. So if that parent is answering that questionnaire, even in tree, he's thinking about the child who is. Do you get a point? And so you have children. In other words, children with maybe if you are using this tool to monitor improvement, ADHD, those children who are sitting there but still touching things will be missed by this tool because of the language issues. So there are many more examples. I'll just end with the implications of this. I've already hinted on them. That these problems that we are unearthing show that it has psychometric implications, false positives, false negatives. But it also shows the importance of co-production, because a lot of these items, because we ask the people, the target audience, because in academics we sit in our ivory tower. How do we typically do translation of instruments? We'll get a bunch of university educated bilingual people who we think represent the people we are going to use the tool among. So I'll pick myself, maybe I'll get some my colleague residents, I'll get some research assistants, translate forward and back. And then, but the terms that they will use, even in the local languages, sometimes there were significant differences in the way that even the local languages is understood. So I'm not explaining it well, but it's important that go to the people who the tool will be used among and involve them in your development of the tool. That's what I'm trying to say by co-production. Format of administration. Some teenagers were reticent that they said that there are some of the items that they will be too embarrassed to ever disclose if it is face-to-face interview format. They would rather sit down and answer it themselves. So that was an important lesson there. And then, of course, the public health and health promotion implications. Because now that we know, for example, that they are using terms like playfulness and laziness to describe some executive dysfunction, it means that when we are going out there to do our public education about, let's say, ADHD and things like that, we know the terms that we are going to use, that, it's not all the Nkola who are agro-women, so that it's because it's just bad character. Some of them may actually have distractibility or executive dysfunction problems. So in our health promotion, we know which terms are being used by the lay people on the ground. So I didn't get a chance to talk about Ifeanyi, but let me stop here. Thank you.
Wow. Very educating. It is now time for us to ask questions, but because time is not a friend to us now, we are going to entertain only 2 questions. Only 2. And as you ask your question, 3 presenters, wherever they are, will hand over the other microphone to them so they respond to your question quickly, and then we proceed. Okay, Doc. So please, I want our presenters to be ready and then listen to the question carefully.
My question goes to Dr. Kalilu Jare. What is your definition of spirituality in the context in which you conducted this research?
Spirituality is like one searching for meaning and belonging, and then the core values that influences that individual's behavior. Then this tool we use, when we analyze it, we realize that it has spirituality concepts. That's why we use the tool. But and then other authors also said that spirituality is synonymous to religiosity. Then we still believe that we can use the tool. But I know that there are some authors who have different meaning of spirituality from religiosity. Too. Okay, thank you.
Yeah. Hello. Yeah. My own goes to Dr. Kwabna. That we did a study about mental health concepts in Akan speaking. So we did it in Ankafo, Koforidua, and Kumasi. And we found that all of them were, doctors, patients were code mixing. So at a time we are not developing our local languages. And we have the people today hardly speaking a pure local language. What even make you think the concept they have about what they are explaining is what they actually mean? Because currently, some words, at least since I was in Kumasi, the same word has changed meaning now because of the code mixing. So how then do you know that this word is still the same concept as is used in the Twi language, for instance?
Yeah. It's a fantastic question, and in fact, it even helps make my case for me, because that's precisely the point that we are making, that language is dynamic and language is complex. So if somebody uses a word, especially in the context of tools that are supposed to be standardized, quote unquote. So in other words, if you say something is standardized, it means that everybody or most people understand it in the same way. So especially in that context, if we take a word and then we use that word in a tool, or even in our day-to-day interaction, and then you assume that the person listening to you understands, even if they say, oh, do you understand? Yes, yes, yes. What do I mean? And then you realize, doctors, we face it all the time. You will go through the whole medication, the treatment plan. Mama, what I say, and Mrs. saying, the money, this will cost this amount of money. It's like all that you said. The only thing that she heard was, the money. So I guess what I'm trying to say is that especially in the context of research or in standardization of tools, you need to go beyond just assuming that they have understood the word that you have used based on face value or based on a very superficial interaction. And that's why in our study, it was very interesting. When they say, oh, they understand, I let them give examples. So one person can talk at length for like 10 minutes with 3 or 4 different examples. And it's from that examples that they are giving that we now, and that's where the subjectivity of research comes in. We now read and deduce or make meaning from that example. That have they really understood it in the same way that it was intended by the tool makers? So the tool makers manual says this item is accessible. So another good example that a tool that is asking about an item that's asking about easy distractibility, where my child is able to has difficulty with items that have multiple steps. The tool is actually trying to ask about being easily distractible. So if you have like cooking or any task that requires more than one step, by the time they've done step 1, by the time they've chopped the tomatoes, something has passed, they've distracted. But you find that you ask them, do you understand this item? Yes. Can you give me an example? And then they start talking about, maybe your parents don't have money to give you to do the task, or maybe basically extrinsic factors. So they are thinking about the item in terms of you don't have the strength, or your parents are poor, but not in terms of like intrinsic factors like being distracted. So you have assumed that, oh, they understood this, you've translated it and you understand the item or the word. But from the examples they are given, and it's consistent, everybody is talking about the same thing, you realize that no. And that person will answer your questionnaire. You think you've got some quality data, but they are thinking of something else entirely. And it's a real problem, especially for us in cross-cultural context where we don't develop our own tools. We bring people's tools and translate them. If it has been developed within our culture, we may have that problem much less. So it's a major thing that I'm really trying to draw attention of researchers within cross-cultural context, developing countries, to be aware of that these problems are there, and at least try and do something to mitigate it. Or even if you won't, just know that not everything that you are getting may be what you think you are getting. Yeah. Thank you for that question.
A round of applause. Round of applause for the questions and the answers. Yes, so we proceed. We have a solidarity message here from pharmacists in mental health, and that is going to be done by Dr. Uyafi. Please, a round of applause for Dr. Uyafi. You're welcome, Doc. You look cute. Very portable.
Thank you. We wish to stand on the existing protocols and address you. Please, we are from the Whole Teaching Hospital, pharmacist, and then we are representing Dr. Richmond Adusapoku, who is the inaugural president of the pharmacists in mental health Ghana. It is an honor and a privilege to stand before you today, representing pharmacists in mental health Ghana. We come here not only as healthcare professionals, but as advocates for the universal human rights to mental health. It is the spirit of solidarity in which we echo the sentiments that our minds are indeed our rights. And it is our collective responsibility to protect and uphold the fundamental human rights. In our daily lives, whether at work, in our communities, or within our families, we should be mindful and empathetic. By being observant and offering a listening ear, we can spot behavioral challenges or changes in our colleagues, family members, and friends. This simple act of compassion can make a world of difference as people often open up and share their struggles. Just as physical health is a right, so is mental health. Together, we must strive to destigmatize mental health challenges and ensure that access to mental health services is equitable and available to all who need it. The well-being of our society hinges on the well-being of its members. Representing the inaugural president of Pharmacists in Mental Health Ghana, we stand in solidarity with the Psychiatric Association of Ghana in our quest to create hope in the lives of patients. Let us continue to work together, hand in hand, to protect and maintain the universal human right to mental health, for it is a fundamental and undeniable right for every individual. This gathering is a testament to our commitment to the well-being and mental health of all Ghanaians. Thank you.
Okay. So, next on our program is a forum by our platinum sponsor, Janssen, and it will be done by Emmanuel Asante-Entry, the Key Accounts Manager and Product Specialist. Thank you. Welcome.
Thank you very much. Good afternoon, ladies and gentlemen. Permit me to also stand on all existing protocols established. On behalf of Johnson & Johnson, I stand here to extend warm regards to the Psychiatric Association of Ghana. And let me hasten to indicate that officially, Janssen has evolved to Johnson & Johnson Innovative Medicine. I think most of us sometimes got confused about Janssen and Johnson & Johnson. So just about a month ago, globally, Janssen, the brand Janssen, which is a subset of Johnson & Johnson, has evolved in terms of nomenclature to Johnson & Johnson. So probably from next year, you'll be hearing a lot more about Johnson & Johnson innovative medicines and not Janssen. So that is just by way of information, and it's a testament to our commitment when it comes to research and development of innovative medicines for some of the very complicated diseases that confront us. And we are very honored to be involved with this conference as the platinum sponsor. So, very brief. We've had a long day. Very brief. I'm just going to highlight briefly our commitment to mental health care in Ghana. And I'll be very snappy. So, like I said, for several years, for several decades, we actually have been working in collaborations with our stakeholders to confront some of the most devastating complex diseases in the world. And in Ghana, we have medications that covers cardiovascular. We have our vaccines still around. And then when it comes to mental health, we also have some innovative medications for schizophrenia. And we also have Concerta. Let me mention that because I sparingly talk about that. But we also have Concerta for ADHD. And beyond that, we do recognize the fact that we work in an ecosystem and we work in close collaboration with our stakeholders to shape the mental health care space. So like I said, I just want to highlight what we are doing within the mental health care space in Ghana. And the pictures you see here, unfortunately, we couldn't project over here because our security system on my laptop didn't allow me to transfer the file to my brother Agorinya, Dr. Agorinya. So please permit me. But the pictures you see here are pictures of the Johnson & Johnson team and the Kwame Nkrumah University of Science and Technology leadership. So the Vice Chancellor, you see the Vice Chancellor there. And this is a memorandum of understanding agreement we went with the university leadership. And essentially, we, as a team in Ghana, we have identified awareness, lack of awareness as a critical pain point. And so we went into partnership with the university hospital and the leadership of the University of Kwame Nkrumah University of Science and Technology to sign a memorandum of understanding which would help the university embark on a massive awareness campaign. And I'm very excited that we are going to be working with the PAG to deploy that awareness activity in the university. And the entire budget is over $50,000. Let me say that. And this, we signed this just about a month ago. And it's a 360-degree strategy where we empower the frontline healthcare professionals. We increase the level of awareness. We try and deal with stigma. So on the campuses, there will be a lot of billboards with contact numbers. There will be a lot of capacity building for the peer counselors. It's quite a robust strategy. And before the end of the year, we are going to replicate this model at the University of Ghana. And I would like to thank Dr. Ruth Owusu-Antwi for the support to accelerate this project. So this is one of our, Dr. Agorinya, please click. I'm sorry, we have quite a very tight security when it comes to our laptop. So this is one of the projects we are doing. And again, we were very happy to have been a part of this public lecture, the Professor E.F.B. Foster public lecture that came off, last 2 months? And that was a fantastic initiative, and want to assure the Mental Health Authority of our commitment to delivering this lecture every year, just to increase the level of awareness within the country. And on this note, I would like to thank the CEO of Mental Health Authority, for the support. Thank you very much, Prof. And this is also a forum that came off last year with the support of Prof. Osei and all the senior leaders in the mental health care space to look at the funding options. And this was quite a very robust engagement. So as a company, beyond making available our medications, we work with our stakeholders to address some of the critical challenges when it comes to mental health care in Ghana. I brought these pictures to also highlight some of the activities we do beyond Accra and Kumasi. So earlier this year, I was in Bolga. I was with Dr. Dennis. We were able to put together mental health nurses from all corners, and Dr. Dennis was able to deploy a very fantastic workshop for them. And based on engagement with him, we realized that there was an issue with referral pathways. So we wanted to crystallize some sort of model so nurses can be emboldened to reach out to him as the only psychiatrist in the Upper East region. So that was a fantastic meeting. And the other, those pictures too, I was in Tamale. I was in Tamale for like a week, and I had some very nice engagement with mental health nurses with the support of Dr. Kumsin. He also delivered a fantastic workshop for all the nurses and empower them. In the coming months, we look forward to extending some of these workshops to the Eastern region. Hopefully, when there is a psychiatrist in the Western region, we would like to collaborate with the psychiatrists there to also bring together all the mental health nurses scattered across, the Western region towards Takwa, so we can build capacity and ensure that the service delivery is optimum. So these are some of the things we are doing as a company in the country. So as I bring my presentation to a close, I wanted to indicate that when it comes to medications, we have been with you from the beginning. For many, many years, we have been investing a lot in research and development when it comes to antipsychotics. I started my career with AstraZeneca. I launched Crestor with the team back then. I launched Atacand. I launched Nexium. And when I left AstraZeneca and I found myself in J&J, I noticed that Johnson & Johnson is more like a lone ranger. There are some other companies within the mental health space, but when it comes to the big giants, you don't see them within the mental health care space. And I understood that it's as a result of the complexities and the risk that has to do with mental health care. And G&J, for many years, we've been investing a lot. And this is just to indicate that we want to make available our innovative medicines here in Ghana and want to sustain the business. Previously, when you want some of these innovative medications, you have to travel all the way abroad. But we have actually, addressed a lot of challenges to make it available here for patients who require them. So we launched Travicta earlier this, I think somewhere in June. So this is just a short clip. Unfortunately, let me see if I can put the microphone. That's Dr. Ruth. Yeah, that's Dr. Fiagwe. So this launch came off somewhere in June, July. and the launch of our innovative Trevicta 3-monthly paliperidone palmitate. Currently, globally, we are the only second generation 3-monthly long-acting antipsychotic. And so just briefly to indicate that it's the ultimate schizophrenia treatment option, offering patients meaningful moments in life. So my last slide is just going to show you just the pharmacokinetic property of Trevicta, and then I'll bring my presentation to a close. So this is just illustrating the pharmacokinetic property of Trevicta. Okay, so it's a very short
For more
video.
than 60 years, Janssen has been committed to minimizing the burden of disease for people living with mental health disorders such as schizophrenia. While many disease areas have experienced rapid innovation in recent years, schizophrenia has generally not seen the same focus and attention. Through our medicines development program, we aim to change this. The Trevicta plan is the latest example of this, representing Invega Sustenna, once monthly paliperidone palmitate, and Trevicta, 4 per year paliperidone palmitate. With the unique 4 per year dosing of Trevicta, Janssen is realizing its ongoing commitment to giving patients with schizophrenia freedom from the frequent administration of daily oral antipsychotics and helping them to live the lives that matter to them. But how can Trevicta deliver this unique 4 per year dosing? Let's take a closer look at its administration and pharmacokinetic characteristics. Following 15 seconds of vigorous shaking to ensure a homogeneous suspension, select and detach the correct needle. Trevicta is injected slowly into either a deltoid or gluteal muscle, using only the thin-walled needles provided. For guidance on needle selection with Trevicta, see the summary of product characteristics. Trevicta must be injected within 5 minutes after shaking to avoid sedimentation of the suspension prior to administration. Trevicta is composed of insoluble microparticles, each of which are composed of thousands of molecules of paliperidone palmitate. These microparticles are slowly broken down over time, gradually releasing molecules of paliperidone palmitate into the muscle, enabling the 4 per year dosing of Trevicta. Esterase enzymes present in muscle tissue metabolize these paliperidone palmitate molecules, cleaving the palmitate from the molecule and resulting in the creation of palmitic acid and the active paliperidone. The palmitic acid is naturally reabsorbed as a long fatty acid by muscle and other tissues, and the active paliperidone enters the circulation. This molecular structure, combined with an increased particle size and concentration of paliperidone palmitate compared with Invega Sustenna, results in prolonged release and absorption characteristics, which facilitate the unique 4 per year dosing of Trevicta. In preclinical studies, paliperidone plasma concentrations gradually rise following a single intramuscular dose of Invega Sustenna, reaching peak levels after a median of 13 days, with a median apparent half-life of 25 to 49 days driving its subsequent elimination from the body. In preclinical studies with Trevicta, peak plasma concentrations gradually rise with a single intramuscular administration until they reach a peak level after a median of 30 to 33 days, with a median apparent half-life of 84 to 95 days following deltoid injections and 118 to 139 days following gluteal injections. As such, When administered in 3 monthly intervals and at doses that are 3.5-fold higher than the corresponding dose of Invega Sustenna, Trivecta results in similar paliperidone exposure, efficacy, and safety to that reported with corresponding monthly doses of Invega Sustenna. Paliperidone passes through the blood-brain barrier and travels through the cerebrospinal fluid to specific receptors on a patient's neurons. At the neuron, paliperidone binds strongly to serotonergic 5-HT2 receptors, altering the availability of serotonin within synapses, and also antagonizes dopaminergic D2 receptors, altering the availability of dopamine within synapses and manipulating the mesolimbic, mesocortical, nigrostriatal and tubuloinfundular pathways associated with the pathophysiology of schizophrenia. In fact, these D2 and 5-HT2 receptors are believed to be involved in the manifestation of positive and negative symptoms of schizophrenia. With 2 formulations allowing the sustained release of paliperidone, the Trivicta plan offers a convenient treatment solution for both you and your patients. What's more, with the Trivicta plan, you can support your patients throughout their schizophrenia journey with the consistency and convenience of established and related formulations, guiding them from once monthly Invega Sustenna towards the freedom of the only 4 per year treatment. To learn more about the benefits of Trivicta and the Trivicta plan, visit.
Thank you very much. I'm grateful for your time. Please, if you do have any question, you can reach out to me at the back. We are very grateful. Thank you.
Thank you very much. We're still going to hear a message from Spectra, and we'll invite Mr. Albert Brew. Please, let's put our hands together for Mr. Albert. And remember, they are part of our sponsors. They are one of our sponsors. But I've made an observation. Why all the sponsors, they are handsome, cute, and they are hairy? Probably there's something I need to know later. You're welcome.
Thank you. All right, thank you. And I bring you greetings from the Spectra Group. I have my executive director of the group with us, Dr. Asafoetey Frimpong, and one of my colleagues. So on behalf of the entire group and the team that is here, we bring you greetings, and we are so happy to be here with you this afternoon as we talk about partnership. All right. So Spectra Care is part of a group of company called Spectra. And I'm sure most of you are familiar with Spectra when it comes to health imaging. We are a household name. We are also in the insurance sector, offering a mutual insurance package heavily in the market as well. In terms of, okay. To speak of our vision, it's pretty simple, and we are saying that we want to make healthcare accessible to all homes and communities through innovation and technology, and improve health outcomes through informed insight. We'll be looking at why we say this in just about 5 minutes, and then I'll give you the rest of the time. When we talk about health, so 3 things actually come out very specific in our vision. We're talking about 3 things here. Health technologies, we are talking about health expertise, and we are talking about secure platform. So we are marrying health technology, we are marrying with expertise, and we are delivering that virtually through a secure platform. What are we talking about in terms of health technology? We have devices that makes virtual consultation pretty much possible. I'll briefly talk about that, and then we go into specifically how our partnership would work in terms of Spectra and your organization. So we have an integrated 6-in-1 monitoring device which monitors your BP, which monitors the patient's heart rate, which monitors blood sugar, blood oxygen, and all of that. We have a digital stethoscope which helps in the virtual patient heart, lung, and abdomen function assessment. And we have a digital otoscope as well which helps in the virtual ENT and skin checks. Now, when we move on further, our expertise is where our partnership comes in. So having all of these devices made available to individuals, made available to organizations, and made available to schools, then we need to put these devices and the data that comes from it before the experts. And that is where the practitioners come in. So on our platform, we also collaborate with GPs, with specialists across all fields, on demand for virtual physical health consultation. And then we create access for our partner psychologists and psychiatrists for private and confidential mental health consultations and counseling as well. So our platform is a telemedicine, a novel telemedicine platform, which allows you to do video, audio, and text consultations with the possibility of doing a conference consultation if possible. So in case you want a colleague of yours to join in the consultation, that is possible. In case you want a parent or another person to join in that consultation, that is also possible. We are able to design, or you are able to design a specialized care for the patient that you are seeing. We have our integrated vitals monitoring from the devices that we make available. We have patient confidentiality is possible and is highly key on our platform. And then you are able to get continuity of care as a result of the data that is available and the continuous care that is kept on the system for you, the provider. You are also able to issue e-lab script and prescriptions where that is applicable, and you're also able to book appointments, set them, and you get reminders for these appointments. Our platform is very easy to use. It is lightweight, which means that you need very little data to be able to access it. Patients access different groups of practitioners, including your very cells on our platform, and we have been able to integrate it with the devices that we are talking about, so that if you are transcribing data from the device to the platform, it doesn't have to be manual to check against errors and all of that. What are we offering? We are saying that by using our platform, patients are able to reach providers wherever they are. I heard the gentleman that presented ahead of us saying that there is only one psychiatrist somewhere in the north, and there is none in the western region. That means that this is a platform that enables you to reach somebody in the western region. This is a platform that enables you to reach somebody in a region where there is no colleague. And even if it is one colleague that is out there, imagine the load of work that is upon that colleague. So we are saying we are partnering with you to make this accessible everywhere and to make your services and your expertise accessible there as well. In terms of what we are doing, we have created a community on our platform. What are the communities we have created? We have partnered with schools, junior high schools, senior high schools, tertiary institutions, and we have given them our solution. So what that means is that in a tertiary institution, every student on his phone has an access and is going to be able to reach you for a consultation. In a second cycle institution, what we have done is that we are giving them packages that includes consultations with yourselves and other specialists. In junior high schools, that is the same thing we are doing. Now, when it comes to organizations, both public and private organizations, we are making packages available to them that would enable them from the very comfort of their boardroom or even their very desk, be able to access help from you. Now, in our research, we realized that an estimated 10 to 13% of Ghanaians have some conditions, and this is something that is very well known to you. And the gap in care is about 98%. So on the community that we are building and creating, we do not want these statistics on that community. So on Spectra Care platform, we want to change the narrative of these statistics that are on there to make sure that help is available and accessible to everybody. One thing that concerns us and why we are partnering with schools a lot is the increasing prevalence of suicide on there. So our drive is to ensure that every student is aware of your presence on our app. And this is not, our solution is not such that the student will decide whether or not to be part of the program. We are working with the school body so that it is available to every student, right? So that if a student needs help, it will be easy for that student to get that help. We know that it is one of the major blockers to mental health care and assessing mental health services is, accessibility. It is difficult for people sometimes to walk in. But our research found out that if this is before it's available virtually and an individual can pick up his mobile phone, his laptop, and book an appointment for help when that is needed, that help is easily taken and that help is easily assessed. We know also that a black man does not want to be seen a shrink. So if the black man in his room, in his conference room, at his desk will be able to access help, then that makes it entirely easy and that bridges the gap that we are all looking to bridge in terms of mental health care. Now, we are calling on you in full partnership to change the statistics and to change the narrative. Our solution offers full privacy, both for what you are doing and for the care that you are providing to the patient. Our solution promotes early help seeking, because if I know that I can get help without a stigma that is attached to it, then it will be easy for me to proactively seek that help. And that means that, and why we are in the schools and colleges is that we want to cement this in their health seeking behavior, right? So that as they grow, it becomes normal for them to seek the help that they need when they need it. So our partnership is going to help all of us to change the narrative, which is something that I know PAG really wants to do. So what is in it for you? Getting on our platform means having access to a large community of individuals, both from student population, from the working class, from individual communities. There are other things that we are working on, which includes partnering with pharmacies across to make the access points, to build access points. So we are partnering with clinics within communities, we are partnering with community pharmacies to create access points there where people can just walk in and be able to book an appointment and to see one of you. Our health data security management is top-notch and there is no gaps in there. We are heavily DPA compliant and we are heavily registered with the Ghana Data Protection Authority as well. So, calling on all of you to join us in this partnership. We have our forms at the back. If you have any questions, we'll be happy to take it on our desk. But we would also want to create a platform because there is a whole lot to come. Some of you are already on our platform. Dr. Pearl is already on our platform. And we want all of you to join because the numbers that are there cannot be taken care of by just one person. So we'll be creating a group where we'll be able to share a lot of information with you on the next steps and what we are doing and how we need you involved and where we need you to tackle. So kindly bear with us when we take your numbers and we collaborate. We put all of you in a collaboration to be able to share the relevant information with you. We will be available at the back to take questions if there are any. Thank you very much.
Thank you very much. Okay, so it is now time for lunch. So we will go straight to where we're going to take our lunch. You know where we had a breakfast in the morning. just down there. That is where we're going to have a lunch. And please, if you are here and since morning till now, you have not even taken an individual picture, I am here to inform you that it's a crime. Yes. So please, don't leave here. Sure. So don't leave here without taking a picture. But before we step out, we are going to do a group picture now. We're going to do a group picture now. I remember a picture that we took. When I later saw the picture, I saw where I was standing. The place was empty, but I was in the picture. If you know you are one, don't come inside the picture. So please, let's move forward. Let's move forward and do a group photograph before we go down to take our meal. And please, when we come back, at the backdrop, we can take a lot of pictures. It's very necessary. So please, let's move forward. And then we are also doing a poster presentation. So if you check your back, you see posters on the wall. Okay. When after our lunch, we are returning back here quickly, and we need you to go round and look at the posters because you are going to vote, and there's going to be an award for the best poster, and you are the best person to do the voting. So please make sure you have a look. Okay, so we also do sip and paint after lunch. Sip and paint after lunch. So please, let's move forward and do justice to the photograph, and then we can proceed for our lunch. Thank you. Hello. Hello, please, can we move forward? Thank you.